Alrighty. Okay, so if you want to maybe scoot a little bit forward, or you know what, if you want, you can get right here. Okay, that would work.
Hey guys, we'll be getting started just in a few minutes. We're waiting for some of the hub members to get here. Thank you.
Hi, can you hear us?
Yeah, we can hear you. Can you hear us?
Yes.
Great.
Hi, Dr. Heather has a presentation. He'll be here in just a second.
Perfect, thank you. I'm so sorry. I was trying to touch, it's the same as our submission one looks.
Okay.
It's the same for everybody.
Okay.
This one.
Oh,
Yeah.
okay, good. Nice, nice. Dr.
Yeah, it's admin.
Oh, I see. Oh, I think he's in the room now. Thanks.
Yeah. Oh, okay, thank you. Yeah.
All right, I think we'll go ahead and get started. We're just running 2 minutes behind. I know some more people will jump on, but just for the sake of conversation and time and stuff, we'll get started. So Dr. Hatter has a presentation. We have plenty of time for questions and discussions, and if anybody has a case they would like to talk about, we're open to that. But first we'll start with introductions, and I'm gonna ask the hub members there. Dr. Hatter, do you want to start?
Yes, I'm Dr. Heather, I'm endocrinologist here at Morgantown.
I'm Dr. Perini, also endocrinology here. I'm Jennifer, I'm one of the endocrine fellows.
Perfect, thank you all. All right, and Dr. Rexroad?
Hi, I'm Carmen Rexroad, family physician at Pendleton Community Care in Franklin.
Perfect, thank you so much. All right, and then Ellie?
Hi, all. My name is Ellie Cordova. I work at the Echo Institute in Albuquerque, New Mexico, and we're just here to observe today. Thank you for having us.
Hi, my name is Kelly Seiss. I also work here in Albuquerque as an operations specialist. Thank you.
Great, thank you both. So everybody, I'm Caitlin Endinger, one of the Project Echo coordinators.
Hi, I'm Mitra Motasham, and I am also a Project Echo coordinator.
Perfect. I do expect some more people to jump on, but never fear, there's always time. So Dr. Hatter, I'm going to unmute you. Do you want to start, or did you guys have anything you wanted to talk about before the presentation?
No, I think we can start.
Okay, wonderful. I see MVA is getting ready to get on, so that's who's right there, but that's okay. I'm going to share it, and then you can just tell me how to go through your presentation, okay?
Oh, okay, so am I ready to start?
Yes, you are, whenever you're ready.
Okay, so I want to talk about, fasting hyperglycemia in diabetic patients. So, so what should we think about when we see someone with persistent fasting hyperglycemia, both type 1 and type 2 diabetes? Next slide, please. So I will talk about a case. So this is a patient that I saw in July. She is a type 2 diabetic, and she is on insulin, and these are her blood sugars. And so she has had diabetes for at least now 12 years. She was close to 30 when she was diagnosed, and now she's about 42. She has been on insulin for the last at least 6 years, according to her. Initially, it was just on basal insulin, but these are her current regimen. This is what she's taking. So she's on 100 units of Lentis. She takes it at bedtime. And she takes pre-meal a Novolog, 20 units with breakfast, 30 with lunch and dinner, about 15 minutes before. She's trying her best. As you can see, she's checking blood sugars multiple times. She's also on metformin, so a good, good therapy. She was tried on other medications like GLP before, but she had some side effects from it, nausea, vomiting, so she cannot tolerate it. But if you look at her blood sugars here, you see that her fasting numbers, most of the fasting numbers are kind of high. In fact, some are very high, and some are actually low as well. There is a couple of 60s in there. There is some good numbers as well, hundreds, but there are some very high numbers, 516, 400s. So clearly, an erratic pattern only in the morning. But then she takes her injections, her pre-meal injections, and sometimes she's okay, and sometimes she is still high. Same thing is happening around lunchtime and at bedtime or around dinner time. Post dinner, she's running low. So maybe some stacking of insulin taking place, and the blood sugars are running low. There are a lot of tight numbers post dinner. So it's a challenge. So predominantly there are two challenges here. She's stacking insulin and causing low here, which is causing rebound high, or if there is something else going on, and what should be the approach. So that's a case I picked for today, and we will talk about how to manage. What is my approach when I see this kind of a pattern. Next slide, please. So, a few concepts before we come back to this case and work and talk about the approach. So, insulin resistance increases overnight. There is a diurnal variation in how liver releases or manages glucose at night. when we are sleeping, our liver is not sleeping. It is making glucose. It's called gluconeogenesis. So it's using the protein and the carbohydrate, proteins and the fats that we had consumed during the day and converting it into glucose and releasing it. And it's also releasing the glucose from the stores of glucose. So that's glycogenolysis. So glycogen stores are converted into glucose and released into the circulation. This happens in all individuals, including normal individuals, more so in diabetics. So the way we can approach this is, of course, by eating better, diet, weight loss, especially if patients have NASH or fatty liver. If we improve that, this will improve. Using diabetes medications, especially metformin will help. GLPs also help with that, and of course insulin, because insulin will suppress the gluconeogenesis or the glucose production and also the release. So that's one way to do it. So that happens commonly. And the other way, and the other reason that the glucose rises at night is because of the release of stress hormones, growth hormones, predominantly. And this again happens in all individuals. Now, if the patient has a certain stressful situation at night, especially obstructive sleep apnea, the stress levels will go high because the oxygens are dropping, and the blood sugars will actually rise. And in obstructive sleep apnea patients, they will have persistent fasting hyperglycemia, and it will improve after CPAP. So if you have an obese patient who's complaining of tiredness, fatigue, and you are considering the diagnosis of obstructive sleep apnea, I think that is something that you should do a sleep study and then treat it, because that will help the stress levels and indirectly will help the blood sugars. And again, this happens in diabetics and in normal individuals. But if in a normal individual, if this is taking place, if the liver is making and releasing more, then the insulin will rise and will suppress this. Whereas in type 2 diabetics, and also, of course, in type 1 diabetics, because the beta cells are not there, this will not happen. So if their glucose, if their liver is making more glucose and releasing it into the circulation, their blood sugars will be higher. Whereas a normal individual, increased insulin production will take care of it. Next slide. These are two things to consider here. One is called the dawn phenomena, and the other is called the Samoji phenomena. So dawn phenomena is basically increase in blood sugar in early morning, and this happens predominantly because of the hormone release, predominantly in the early hours of the morning. So after 3 a.m., the growth hormone production, the cortisol production will increase. And if these hormones are increasing, there is more insulin resistance. So the same insulin, the same dose that they are taken, is not working that effectively because of these hormones. And as a result, there is the blood sugars will rise. So in contrast to this dawn phenomena, there is a Samoji phenomena. And this happens because, the high blood sugars are high in the morning, just like in the dawn phenomena, but this is a rebound high, meaning that the patient's blood sugars drop, and then the counter-regulatory hormones, all the stress hormones, the epinephrine, norepinephrine production increase, and now the blood sugars are high in the morning. So both these phenomena will cause fasting hyperglycemia, but the cause is different, and as you will see later, the treatment is entirely different. So this is what I'm getting to make this differentiation in patients when we see hyperglycemia. Next slide. And again, this is just the depiction of what happens in the Samoji phenomena. So patient is going to bed. This is the time here, and these are the blood glucose levels. So the blood glucose is okay. The patient goes to bed, and maybe he or she took some insulin here, which is causing blood sugars to drop low into the 40s, close to 30s, and all these counter-regulatory hormones are kicking in and causing the blood sugars to be high. So the patient is waking up with high blood sugars, and if you don't know what's happening here, you probably will increase the insulin and will make this worse. So this is an important thing to consider. Next slide. Just to re-emphasize this, so clearly there's a difference. So again, in dawn phenomena, there is a progressive rise throughout the night. The liver is releasing more because of the growth hormone and other hormones. So there is no low in the dawn phenomena. There is more insulin resistance, so therefore the blood sugars are rising. Here in Samoji, there is a drop, and after the drop, there is a high. Again, the cause here in the dawn phenomena is not enough insulin. We're talking about diabetic patients, so either the insulin is not lasting long enough, or the dose is not enough, which can suppress these other, or which can counteract these other stress hormones. Here in Samoji, there is too much insulin or not enough carbohydrates, and that's why the insulin is actually, the blood sugars are actually dropping, and then it's rising. So some of the treatments for the dawn phenomena is, of course, we need to know what's happening to the blood sugars. Is the blood sugar okay and then rising? But in the dawn phenomena, where there is not much enough insulin, of course, we need to increase the insulin doses. Insulin pump is one way to deal with this phenomena, where we can set up a different basal rate between 4 to 7 or 4 to 8 a.m. depending on what time they're getting up. Whereas if we are considering Samoji phenomena, then we have to decrease because the blood sugars are dropping, and ask the patients to take snacks at bedtime. Next slide, please. Any questions about this? Okay. The other important thing to remember is how our different insulins work, because if this is happening, these two phenomena are happening either because of too much or too little insulin, we should try to understand how these insulins that we are prescribing to the patients work. So this is just, again, a 24-hour time period, and this is the peak actions and the absorptions of different insulins. So this is our short-acting insulin, the Novolog, Humalog, and Epidra. After injection, it peaks in about 35 to 45 minutes, and then it's almost out of your body by about 4 to 5 hours. So these are the short-acting insulin. The regular insulin, which is also a short-acting insulin, but it has a different profile than these rapid-acting insulins. It peaks in about 2 hours, and then it's out of your system by about 6 hours. NPH, old insulin, cheaper insulin. Sometimes we have to use this insulin, but this is not a true basal insulin. It peaks about 4, maybe 6 hours, and then it lasts in the body for about 14 to 16 hours. So it is, when we are using NPH insulin, especially at bedtime, some patients use it at bedtime. So we must remember that this will peak about 4 to 6 hours after they have taken their injection. And if the blood sugars are dropping, then it could be from the peak action of NPH insulin. The glargine insulin, this is the Lentis, the Basaglar, and the Toujeo. All of these are glargine insulin. This is a true 24-hour insulin. Really does not have a true peak. So after injection, it reaches a steady state level, and it plateaus and stays in that range almost for the next 24 hours. So the profile is different. So really, if the patient is taking glargine insulin, we really don't expect them to have a peak, which is causing the low blood sugars. Next slide. Again, this is just comparing the Lentis insulin, the glargine insulin, with the Levemir, which is, again, basal insulin, but the profile is a little different. Glargine or the Lentis insulin, no true peak, and it lasts for 24 hours, whereas if you see this Levemir insulin, it is almost a 24-hour insulin, but after between 18 to 20 hours, its effects start to come down, and it does have a little bit of a peak as compared to Lentis insulin. It's a slightly different profile. In some patients, when we use Levemir, we use it twice a day for the same reason, especially if they are on higher doses, because it does not have the same half-life as the Lentis insulin. Next slide. Can you press click again? And one more time. And one more, 2 more times. Okay, so this is the same, the dawn phenomena and the Samoji effect again. In Samoji, the patient is going to bed, this is 10 p.m. with okay blood sugars, but then at 3 a.m. the blood sugars are dropping. And as a result of that, the blood sugars are rising in the morning, so they are waking up high. In dawn phenomena, normal blood sugars, and high blood sugars. And if we check the insulin levels at that time in the system, the insulin will stay normal. Whereas in Samoji, it will actually be high because the insulin is peaking around that time and causing the low blood sugar, and then it will become normal. And sometimes there's a combination of the two phenomena together. The insulin, there's a waning of the insulin effect, plus the dawn phenomena is taking place at the same time. So there is not enough insulin, plus all these counter-regulatory hormones are in place, which is causing high blood sugars, and the patients are waking up with high numbers. So just remember, low in Simoji, they're dropping and then rising. In dawn phenomena, they're really not dropping, they're just progressively rising. Next slide. So back to the patient and back to what approach after talking about the insulins and what exactly happens to glucose production at night. The first thing that we should do is to understand patients' lifestyle. Are they exercising? Are they snacking at night? Are they consuming any alcohol, which can cause low blood sugar? So talk to the patient as to what they're doing, what they're snacking on, if they're snacking, when are they taking the last meal of the day. So that's the first thing we should do when we are dealing with this phenomenon where they're waking up with high numbers. Then understanding the insulin profile. What kind of insulin they're using? Are they on NPH insulin, taking it at bedtime? Are they on Levemir, just taking it just before bedtime? Are they using any bolus just at bedtime, like a regular insulin or an NPH insulin, which is causing the low blood sugars? Are they missing insulin injections? That's the other thing. And this is, I think, the most important thing, which some of us may, can forget at times. Their insulin injection site, as to where they are injecting the insulin, and feel that area to see if there is any area of scar tissue developing or lipohypertrophy developing there. Because the insulin absorption will be affected by where they are injecting the insulin. If the insulin is hitting a scar tissue, the absorption of a 24-hour insulin will be erratic. They may or may not absorb insulin. And if we keep increasing the insulin, and one day they absorb all of it, then there will be low blood sugar. So feel the insulin injection sites. Ask about low blood sugar symptoms at night. Some patients will tell you that they wake up and eat something. Some will tell you that they have only problems with nightmares, night sweats at night, and they feel tired in the morning as a result of that. So ask about the nightmares and their sleep quality, and if they're eating something at night, if they're scared about a low blood sugar and snacking before they go to bed. So that's another thing. Most importantly, if we can have them check blood sugars, if they're going to the bathroom around 3 or 4 a.m., have them check the blood sugar, because if you see a low blood sugar, then this will answer your question that if it's the dawn phenomenon or the Simoji phenomenon. And of course, if we can get patients to use the insurance to cover the continuous glucose monitoring system, the CGMS, Dexcom, or Libre sensor, any other kind of sensor, this will give us more information as to what's happening to their blood sugars at night. So the patient I discussed initially, the patient has, she's not very active. She has a sedentary lifestyle. She does not use alcohol. She mentioned that she's getting up at night multiple times because she feels that she's low. She is not checking her blood sugars at the time, and she's sleeping with some sort of candy or orange juice by the bedside because she's concerned that she's dropping. But she's not checking, she just treats her low blood sugar, and then depending on what she consumes, her blood sugars are fluctuating. Next slide. This patient that I've mentioned, she also was obese. Her BMI is more than 40, and so we should consider increased stress at night, during the night, if she has obstructive sleep apnea. And when I'm seeing her, these are the two things I'm thinking about. Is she having exaggerated dawn phenomena? And dawn phenomena can be different in different people. Some people have an exaggerated response, some people don't. So is it a continuous rise? And that will tell me that there is not enough insulin overnight, basal insulin. She's on 100 units at bedtime of Lantus insulin, glargine insulin. So because if it's rising constantly throughout the night, then that means she's not getting enough. However, if her blood sugars are dropping, from her history, from what she's telling me, sounds like she's dropping and rising, then that means we have to reduce the basal insulin, because if I increase the dose, her low blood sugars will increase. We should also, if she's using any bolus close to bedtime, then we should avoid it, because it will peak in about 4 to 6 hours, 2 to 4 hours, and then drop blood sugars. And encourage patient to take snacks, check blood sugars at bedtime. Next slide. And I think this is the most important thing. This is the patient that I mentioned in the first slide. So this is where she's injecting her insulin. This is her favorite spot. She keeps injecting for the last 4 to 5 years. This is the site where she's injecting. And you can easily see, and when I examined her, I found that there is a big scar tissue developing underneath around this area. So I'm really not sure how much she's absorbing when she's taking it, depending on what part of the scar tissue she is hitting. So I think the most important thing here is we all need to look, and if there is any suspicion, feel the area of insulin injection sites. Scar tissue, again, it will, depending on where the injection is, and how much scar tissue there is, it may or may not absorb. And the fluctuations will lead to this pattern of hypo and hyperglycemia, depending on how much insulin is getting absorbed. We should always tell the patients to rotate insulin injection sites. They can use the belly, but I think mostly go on the sides here and on the sides here and other areas. Just not pick one favorite spot and keep using it. Some patients, because the needles and are expensive, they use the same needle or the same injections over and over again, and again the injection it's not as thin after because of the trauma, and it becomes blunt, and that can lead to this kind of scarring or more scarring. And this patient was using the pen needles over and over again just to save some cost, and probably that's what was contributing in her situation. Next slide. So we got her on the pump. So this is in November. We initially saw her in July, but now this is November. So she's coming here now. She has a sensor as well. I don't know if you guys can see it, but this is her basal insulin, and now she's on about 2.5 units per hour. So this is around, 2.5 units, so which is around 60 units. Before she was taking 100 units of basal insulin. So her insulin requirement is now much less because now she's absorbing the insulin better. But still, even in on less insulin, this is again overnight. She's running tight. She is actually dropping close to the 50s, still having some hypoglycemia. And the pump actually is stopping to deliver the insulin because this is a T-slim pump and it can stop if the blood sugars are dropping. So still, even on low doses, she is having the same problem. So she is most likely developing a low blood sugar. Like here, she developed low blood sugar and she consumed some carbohydrates. She covered for it, but even in spite of that, she was high. So her high blood sugars are most likely from a preceding low blood sugar. So we need to reduce her insulin in this situation. And again, compared to how many units she was taking before, her insulin requirements now are much less. About 60% of what she was on before, because now she's actually getting the insulin and it's not hitting the scar tissue. So I saw her last time in November, and we actually reduced her basal insulins her basal rates even more to avoid the hypoglycemias. Next slide, and that will be the last slide. So just to summarize, most important thing here is to examine the insulin injection sites. Ask the patient where they're injecting and then try and feel it. If the blood sugars are running high in the morning, have them check blood sugars around 3 a.m. or 4 a.m. to see if they're dropping or if they are constantly rising. Screen patients for sleep apnea. Severe sleep apnea will cause high blood sugars by increasing the stress hormones and causing the morning sugars to be high. And again, if you're concerned about it, if the patient is telling you that they're eating or they're having nightmares, then reduce basal insulin rather than increasing the basal insulin. If you increase the basal insulin, then you will make this worse. And always, if the insurance is covering the continuous glucose monitoring system, that will be very informative about the glucose patterns at night. That's all I have.
Thank you so much, Dr. Heder. That was wonderful. Does anybody have questions? I know there's a couple people in the room there at MVA. If you guys need help unmuting, you can just wave at me.
I just have a comment. I mean, I think this has been really valuable because I think we've all seen that patient that the blood sugars are all over the map and we don't know what to do with it. I have one that came to mind, well, two that came to mind, but one of them is in a nursing home. So we know what she's getting. We know she's taking her medications, rotating her sites, all those kinds of things, but she's still having sugars all over the map. And so this is, it's given me some food to thought and some ammunition to try to get her better controlled.
Perfect. Thank you, Dr. Rexroad. I had written down a question, if I may, and I was just wondering, after you put them on CPAP and stuff, do you just see better blood sugar numbers in the morning, or does that translate throughout the rest of the day?
Yeah, it does translate throughout the day because they have more energy, they're not as tired, they will be more active during the day. But yes, so fasting blood sugars will improve for sure because the stress levels are, hormone levels are down. But also, if they're more active and they are more energetic, then they will not be just sleeping in their chair throughout the day. So the blood sugars will actually improve. The insulin will work better in that case.
Perfect, thank you.
Overall effect on the blood sugar.
Great. Any other questions, comments, insights? We had a question submitted that Mitra is going to present here. We had a couple people emailing in questions since our last endocrine session was actually a month ago because of the holidays. So if you guys don't care, we were just going to read a couple of those, get some insight onto them.
So one of the questions that was submitted was, what are some tools and instruments used to benchmark care for children who are obese? With the standards through the Endocrine Society, what is recommended to help guide quality improvement initiatives?
So for pediatric issues, those are in guidelines that we don't actually keep up on. I'm not exactly sure what pediatric guidelines would say for obesity. I know that when somebody even comes in to see us who's between 18 and 20, they have special parameters listed for their BMI. So there are different rules that I know I, for one, am not up on because we don't treat kids here. We're just adult endocrine people.
Okay.
There are pediatric endocrinologists at WVU, so perhaps those questions could be, I mean, you could email those questions to Dr. Ely, for example. I'm sure he could help you.
Great, sure. Thank you. There was another question. How can you clinically differentiate between pressure decubitus ulcers versus diabetic foot ulcers?
Position, I think, depending on the patient's position, the pressure ulcers will develop if they are laying in bed for a long time. They normally develop on the bony prominences, so in the sacral area, on the heels, whereas diabetic ulcers can develop, I guess, anywhere. So I think position plus history of diabetes and their control of diabetes, if they have any peripheral vascular disease and other risk factors. I think.
Also, if they have foot deformities that are typical of diabetic feet, for example, Charcot foot, if they've lost the arch of their foot, if they're in weight-bearing areas that are unusual because of the anatomy of the foot having changed, if they have peripheral neuropathy, then the architecture of the feet actually changes, and then they develop pressure ulcers in areas where they wouldn't normally see pressure because, for example, the arch of the foot shouldn't be touching the floor, but if they lose the arch, suddenly that's getting pressure. That would be more typical of somebody with diabetes. So overall, getting non-weight-bearing status onto that ulcer is going to always be the treatment, as far as I understand, whether it's a pressure ulcer or a diabetic foot ulcer. Either way, you want to have them not putting continued pressure on it to help it heal. I think those are some of the main ways to know. But we have a wound care clinic here if anybody needs to see anybody for that.
Thank you.
Great, thank you for that. We had two more questions. One was, why do growth hormones increase blood glucose levels?
Yeah, so growth hormones kind of antagonizes the effects of insulin because the role of growth hormone is to increase the blood glucose, whereas the insulin decreases the blood glucose. So during puberty, when the growth hormones are rising, or during pregnancy, when the placenta is making growth hormone-like substances, it increases the resistance to the insulin because it's working differently on the glucose metabolism, acting on the liver, releasing the glucose, and making more glucose through the liver. So yeah, it's just because it works differently, exactly opposite to the effects of insulin, and therefore it causes insulin resistance.
Great, thank you so much for that explanation. And the final question that we had was, what is the dose of steroids to be given as a pre-medication before amphotericin administration? Pardon me.
You're asking the wrong people. We are endocrinologists. We don't know much about amphotericin, other than its use for fungal infection. And I don't know. Do you know?
If it's for stress, that's an endocrine question. If it's simply to help, decrease some inflammation, or completely separate medication, that would be something to ask ID.
All right. Thank you so much. We'll follow up with them and make sure that they get your comments and stuff, but also make sure what they were asking about there. So thank you guys. So we have 20 minutes left in the session. I don't want to wrap up early, especially if you guys have something you want to ask, talk about, what have you. But I certainly understand. All right. Well, thank you all so much. I'm glad that we could be together for one Wednesday in December. Our next meeting is actually January 8th, so we won't see you guys until the new year, but we're looking forward to it. Dr. Shamsi is going to be starting our curriculum over with the diabetes guidelines, so she'll start back over where Dr. Giordano started over a year ago now. And we'll kind of go from there. If you guys have any case questions in the meantime, please email us. If you guys have any other questions, we'll make sure the endocrinology people get that. And that's it. Everybody have a wonderful, happy holidays and happy new year.
Thanks. You too.
Thank you.
Bye.